Hey everyone, I have another question video for you tonight. Really quickly, I want to talk about the goals of my channel. Really, my channel is going to go into a lot of high yield content, but at the same time, I also am going to go into a deeper dive than most other channels. My goal and the type of videos that I'm going to create, it is really going to be for those test scorers who want to score in the very high ranges, those who are aiming for 260 plus, 265, even in the 270s range. This is what my goal is for this channel. There are plenty of channels out there that are more than sufficient and enough to give you the information needed for a 250 or a 245 or a 255. But the information I'm going to give you is going to be for those who really want to score at the top of the top, 90th percentile, 95th percentile, 99th percentile. And so with that, let's get into this video. We have a 42-year-old male. He presents to the ED, acute shortness of breath, right-sided chest pain, began after severe nausea and vomiting. He has a 25-year pack smoking history. He has COPD on arrival. He's anxious. He has respiratory distress. His pulse is 118, respiratory rate is 32, blood pressure is 94/62. He's satting at 86%. Physical examination, so is JVD, hyperresonance to percussion over the right hemithorax, and decreased breath sounds on the right, with deviation of the trachea to the left. Which of the following is the best next step? And so let's get into these questions and let's get into these answer choices. So X-ray. This is not a bad answer choice. This is we have a lot of COPD, we have a lot of respiratory problems. It's going to give us a look at the lungs and see what's going inside. And so this is not a bad answer choice. So let's keep this for now. Intubation, no, this is just absolutely wrong. There's no, at this point, there is no indication for an intubation. Intubation can be dangerous if you don't know what the diagnosis is, okay? If you're not sure of what the diagnosis is, unless the patient is absolutely, deteriorating, loss of consciousness, and so on, you are going to not want to intubate immediately without knowing what's going on, because there are certain conditions that intubation will worsen, and I'll get into that right after this answer. High flow oxygen observation, this is just not enough, okay? It doesn't even matter if this guy needs oxygen and observation. He definitely does, but this is not enough, guys. Remember what I'm going to continue emphasizing. One of the main points, one of the main goals is these test-taking strategies. We have to look at this picture and let's rate it on a scale of 1 to 10 on severity, okay? Patient, his vital signs are not, he's stable, but he's, just about to become unstable. He's very close. He's almost hypotensive, 94/62. He's at the brisk of, just deteriorating completely. His respiration is 32. He's tachycardic, 86%. I mean, if this drops even, more, then we're going to have a serious problem. So I would say this is maybe an 8, a severity of an 8 presentation. We're going to take these answer choices and basically we want to match which one is closest to an 8. Okay, and like I said earlier, intubation, maybe if this guy was at a 10 severity, you would go with intubation, but based off the presentation, this guy looks like he has a pneumothorax, and if you just intubate and you give them air, that's actually going to worsen the pneumothorax, and I'll talk about that a little bit later. Chest x-ray, like I said earlier, you don't even need to think of the reasoning. When you have a presentation of an 8, a chest x-ray is it's not, you want to match the answer choice severity. The more severe presentation, the more aggressive you're going to be with your answer choices, the more aggressive treatment. Chest x-ray is really neutral. Intubation is too extreme. This would be like if a patient came in with a 10. If they came in with a 10, this is like the most aggressive form of treatment you can give for respiratory failure. High flow oxygen, this is just too little. This is like maybe a 1 or 2. If a patient came in, complaining of very mild symptoms, you would consider this. Next up, we have needle thoracostomy and chest tube. Okay, these two are very similar. They can throw you off. So what's the answer choice? The answer is needle thoracostomy. Okay, this patient is having a tension pneumothorax, and we see that with the hyperresonance to percussion. We see that with decreased breath sounds and deviation to the trachea on the left, especially in the JVD. This one was big, important feature. And for attention pneumothorax, you diagnose it based off clinical symptoms and based off respiratory distress. Patient's going to have hypotension, JVD, a lot of these things. And this actually matches his history of COPD and a 25-year pack smoking history, because it is common. This is going to be a secondary pneumothorax due to his lung disease. And essentially his lungs are very trash to the point where they can burst or a pneumothorax can happen anytime. And so the first emergency treatment you do in attention pneumothorax is a needle thoracostomy. You just insert a needle inside the lung, and you immediately relieve that pressure and allow the lung to re-expand. And so we can actually match this with the 8, if you think about it. A needle thoracostomy is not super aggressive. It's not the final form of treatment, but it is an 8. It is more aggressive than X-ray, more aggressive than high flow and observation. We could just eliminate these based off just matching the answer choice with the exam. And then chest tube, this would be indicated. A chest tube is not enough right now. We need something quick, something reliable, something we could do in the, super quick, just to relieve symptoms and to relieve his vital signs. A chest tube is going to be the definitive treatment for pneumothorax, but in an unstable patient with tension pneumothorax, you're going to get the needle thoracostomy first. That's faster and it's more immediate and it's more life-saving. And then after you place the needle, then you go to the chest tube, okay? So let's get a little bit into pneumothorax. These are some of the risk factors. Smoking, this is actually the strongest risk factor. So look for patients who have a smoking history. Tall, thin habitus. This is more associated with primary pneumothorax, in which is rupture of subpleural apical blebs. And a lot of people, even myself, I was like, what the heck is this? Essentially, this is just, tall people. These are just air bubbles that form, at the top of the lungs, like right here. Small air bubbles, subpleural apical blebs. The pleura is right here. So right below the pleura, these form, and usually they occur in tall, thin patients, and then they can just rupture anytime, and then boom, you have some air filling up right here, and gets worse. Patients with COPD, most common: asthma, interstitial lung disease, cystic fibrosis. These are less common in terms of NBME. Mechanical ventilation with high PEEP. This can cause a pneumothorax. So if they ever give you a patient who is ventilated for any reason, and then they describe all of a sudden now he's having chest pain and his O2 saturation is decreasing, start thinking of pneumothorax, because when you push all that air into the lungs, it's going to eventually, it has a strong risk factor of rupturing these alveoli, that they can't handle that high PEEP, and it just ruptures, and then now you're just pushing air into the lung, and that's going to cause a pneumothorax. Let's see, we have chest trauma. This is common a lot of times. And then we have iatrogenic injury, central line placement, and thoracentesis can actually cause a pneumothorax and lung biopsy. These are probably less common. But like I said, if you want to score in those high ranges, you have to know these stuff. Thoracentesis, you're poking a needle inside someone's lungs. Just think about it logically. That can cause a pneumothorax. We have primary spontaneous, like we said, rupture of subpleural apical blebs. We have secondary spontaneous. This is rupture of bullae or diseased lung tissue. So this is going to come from, COPD most common. In COPD, you have, let's say this is your left lung, and then this is your right lung. You're going to have these bullae, like air pockets. This is just straight up air, but here it's contained. And if this ruptures, you can get a pneumothorax, okay? Then we have tension pneumothorax. This is the most severe form, which leads to obstructive shock. So look for patients with hypotension. Symptoms: sudden onset dyspnea, ipsilateral pleuritic chest pain. These are very, common. I don't think we need to get into all of these. You should know these by now. Physical exam findings. This is going to help you a lot with differentiating a pneumothorax from a pleural effusion, from a pulmonary embolism, from other differentials. Decreased or absent breath sounds on one side usually. Hyperresonance to percussion. This is super high yield, guys. I mean, this can give you the answer. If you just see this, you can already assume what the answer is. Decreased tactile fremitus. Remember, this is decreased in everything except for pneumonia. Pneumonia is going to be increased, but in tension pneumothorax, it is decreased. And then hypotension, tachycardia, JVD. This one is big, guys. JVD, if you ever see JVD in a patient describing, hyperresonance, it's a tension pneumothorax. Trachea can deviate away from the affected side. Diagnosis, chest x-ray, it diagnoses it. But like I said, if they're stable, you get the chest x-ray. If they're unstable, guys, tension pneumothorax is a clinical diagnosis. The patient is about to die. You don't delay treatment for imaging, okay? You don't say, hey, this patient's deteriorating, let's get him an x-ray. No, you're going to go ahead with the needle thoracostomy. Mediastinal shift and absent lung markings. I'll show you this later. So management principles, guys. First and foremost, step one, hemodynamic stability. Hemodynamic stability is the most important thing to assess. Is the patient stable or unstable? If he's stable, you can get the imaging, confirm what your suspicion is, and then you can proceed with the treatment. If he's unstable, you treat before the imaging, okay? And then management, stable. If it's stable, he's small, primary spontaneous pneumothorax, you can just observe plus oxygen, guys. Really, if it's stable and it's small and he's just having a little bit of chest pain, you can observe and reassess in a couple of hours. Symptomatic, if he's having symptoms, where they're describing symptoms in the vignette, or if it's a large pneumothorax, or if it's bilateral, you're going to put a chest tube. Tension pneumothorax, like we said earlier, needle and then chest tube. Traumatic pneumothorax is going to be chest tube in most cases. If it's an open pneumothorax, this is going to be where a pneumothorax, is entering the lungs from the outside. You're going to put a 3-sided occlusive dressing followed by chest tube. This is just one of those random facts you should know. And here is the placement of a chest tube. 4th or 5th intercostal space between the anterior and mid-axillary line. So, beneath the armpit, essentially. So differential diagnoses, pulmonary embolism, essentially pleuritic chest pain. This is similar. Dyspnea, the same. These two are the same symptoms. A lot of lung diseases are going to have that, especially in the pleura. But you're going to have normal percussion and breath sounds. Pulmonary embolism does not change breath sounds, and it does not change percussion. And look for risk factors for thrombosis, look for immobility, surgery, and cancer. Cardiac tamponade, hypotension, JVD. So these are similar to a tension pneumothorax already. Here we're going to look for muffled heart sounds, and bilateral breath sounds are present. So like we said, cardiac tamponade is not going to affect the breath sounds. What did we say in pneumothorax? It's going to be hyperresonant. Okay. Aortic dissection is going to be tearing chest pain. They're always going to describe tearing chest pain, radiating to the back. Blood pressure differential, normal lung exam. Hemothorax is going to be dullness to percussion. Okay, dullness. This is the biggest factor. Sometimes this is the only thing you can really use to differentiate between a hemothorax and a pneumothorax. So dullness to percussion. Here's some images of a pneumothorax. So you see all of these, these marks right here. You can kind of see the lung tissue. Here it's just black. Okay, this black, absent lung markings, and it's just going to be black. Here is another one, similar, absent lung markings compared to this side. Very easy to spot. Okay, let's do another question. We have a 26-year-old man. He presents with acute left-sided chest pain. Began suddenly while playing basketball 1 hour ago. The pain is sharp. It's worse with inspiration. He reports mild shortness of breath. He has no medical history. Takes no medications. He's 26 years old, so he's healthy. He smokes 1 pack of cigarettes daily. Vital signs, a little bit tachycardic, a little bit tachypneic, 95%, normal tensive. He appears uncomfortable, but he's speaking in full sentences. Examination is slightly decreased breath sounds on the left compared with the right. Percussion is mildly hyperresonant on the left. No JVD. Trachea is midline. Which of the following is most appropriate steps? So, guys, once again, I'm always going to do this, rate the severity of the presentation. This guy, from a 1 to 10, I would probably place him maybe a 4 or 5, okay? Very, very mild presentation. His vital signs are stable. He is... it's just he has some pain. He reports mild shortness of breath. He appears uncomfortable, but he's still speaking in full sentences. This is a very mild, maybe even a 3, okay? So just based off of this 3, 4, or 5 presentation, I want to match it with the answer choice that is going to be, reflect the presentation. Start intravenous heparin, that's crazy. Why would we even do that? This is crazy. Let's just knock off. The most aggressive answer choice here, I say, is immediate needle decompression and CT pulmonary. Yeah, probably these two. Needle decompression, intravenous heparin, okay? If this guy had a PE and the presentation was severe, yeah, go with the heparin. If he had a tension pneumothorax, go with the needle decompression. This is just, very aggressive right away. He's 26 years old. He has no reason to have a PE. So now we can go with CTA or obtain a chest x-ray. I would go with the chest x-ray. We're thinking of a pneumothorax. This matches the severity of a 3 or 4 or 5. You get a chest x-ray, get some more information and figure out what's going on. And that's it.